मग आपल्याला 1 तास आधी निघावं लागेल.
जास्त
10:30 वाजता.
पावणे 11
हो, 1 तास लागेल.
Harshi, who is answering today?
Sir, Dr. Ashay and Dr. Ankit are answering today.
Yes, sir, I am answering.
Ashay. Okay. So Ankit and Ashay.
Yes, sir.
Yes, sir, good
Ankit,
evening.
you are from?
Sir, I am from Medanta, Lucknow.
Very good. Nanda.
DNB third year, sir.
So your exams are not in April.
No, sir.
Good. Then we have got enough of time to revise the whole thing, means to do the whole thing.
Yes, sir.
Fine. So I think we can start now. Hiren, good evening.
Good evening, sir. Good evening.
So I think we should start now.
Yes, sir.
Pankaj is not in the town.
I'm not aware, sir.
Yeah, because I'm not able to contact him.
Maybe, sir, I think that conference was there, no? EAU.
Nanda. Yeah, but people have gone there.
Ah, I don't know, sir, whether he has traveled or not because he was saying I'm leaving on the 8th or something. In Goa, he mentioned to me, sir, that he's leaving on the 8th.
Oh, okay. Then he must not be here.
Maybe, sir. We can start, sir, with the presentation.
Yeah, 1 second. Huh? He can. Harshu?
Yes, sir. So today we are continuing with the last week's discussion on symptomatology, and we are continuing with the topic of hematuria. So in hematuria, we want to go through the definitions, the difference between microscopic and gross, true versus false, and then describe the types of hematuria and the interpretation that can be there.
So, Harshu, just what we have decided is that few slides we will just discuss it out.
Yes, sir.
Okay. So, anyway, Ashay,
Yes, sir.
so what is the definition microscopic and gross hematuria as per your guidelines given in the books, and what is true versus false hematuria?
Sir, microscopic hematuria is the presence of more than equal to 3 red blood cells per high power field on urine microscopy in a properly corrected urine sample. And gross hematuria is the presence of visible or visible red urine that is visible to the naked eye.
And true versus false hematuria?
And sir, false hematuria can be hemoglobinuria or myoglobinuria, which is in which the dipstick is positive, but there are no red blood cells on microscopy. So it
Can
is
be
a
also.
false positive. And also false can be due to drugs and beet urea.
Yeah. So, Harshu, just go read everything and tell them.
The definition of hematuria is presence of RBCs in urine. Microscopic is when more than 3 RBCs per high power field are found on microscopy, and gross is when there is visible red or brown urine. False hematuria is hemoglobinuria or myoglobinuria, which is found on dipstick but not on microscopy, and it also may be due to drugs and food, which we have discussed in the last session. So the types of hematuria we want to broadly classify as initial, total, or terminal, whether it is gross or microscopic, and whether it is associated with other features such as fever, clots, history of trauma, LUTs, systemic diseases, medication, or addictions.
So, Ashay,
Yes, sir.
what is the meaning of initial, total, and terminal?
Sir, initial hematuria is when the patient says that hematuria is present in the initial stream of urine, and in that the pathology is due to the it is due to urethral pathology,
Okay.
and which may be inflammation.
terminal. No, all the things, initial, total,
And
and
okay,
terminal.
so sir,
So,
and sir, total will be due to bladder pathology or upper urinary tract pathology, and which may be infection, trauma, or tumor. And terminal hematuria is when the patient describes that at the end of the urination there is hematuria, and this is due to bladder neck pathology or like prostate pathology.
So if the patient
The-
says that when he got up in the morning, he
Hmm.
saw that his undergarment
Hmm.
is stained with the blood. What is your interpretation?
Mhm. Sir, uh, sir, I would like to ask more history, and if during
No, I'm just
subsequent
asking you, just
urination there is.
interpretation. When, yes, of course, for
Sir, it.
any
Uh,
symptomatology, ultimately you are going to ask more questions. But when he says
uh,
like that, what is the first thing that comes into your mind?
mhm. Urethral per urethral discharge or something.
Yeah,
I
so
don't know,
it
sir.
is from
Uh,
the distal urethra. I
distal
mean,
urethra.
basically it is
Hmm.
from the urethral bleeding. Correct.
Okay.
Because then there
Hmm.
is no control and it just comes out without
Hmm.
passing urine.
Okay. Yes, sir.
Okay, who else is there? Asha and
Ankit, sir.
Ankit.
pardon?
Ankit Gupta,
Ankit.
sir.
Ankit. So
Yes,
Ankit,
sir.
what do you mean by hemospermia?
Sir, it is a mixture of blood along with passage during the ejaculation, presence of sperm with blood.
So reddish color semen.
Yes, sir.
Okay. So usually how the patient presents when there is hemospermia? Have you come
There,
across any case?
no, sir. Till now, this is mixing.
So Ashay,
Yes, sir.
can you just describe how the patient will present?
There will the the patient will. Uh, Sir, I'm not sure. He may say that
Patient,
after masturbation his semen is red colored,
a patient may present with the
or
lower urinary tract
condom has
syndromes.
red staining. He may say that.
So most of the time it is painless.
Mm.
Okay.
Okay.
Because that usually is not, it is coming from beyond the urethra. If it is there is urethritis and if he gets, then he will have a burning sensation also. But most of the time, so what is your interpretation? If it is patient says I've got just painless hemospermia, means what?
It may be due to UTI or maybe due to ejaculatory duct obstruction.
Sir, so he
Obstruction.
Sorry.
he, he needing along the ejaculatory pathway,
Is it
vesicle.
pathway inflammation of calculi
Sir,
around it.
anything along the pathway can be affected.
Yeah, fine. So if you just routinely, if you want to find out whether patient has got some
Prostate,
urethritis and that is the cause of his hemospermia, okay, what examination you'll do?
seminal vesicle, ejaculatory duct, or
Prostatic
Pardon?
massage secretion examination, sir.
uh,
No, if you do urine routine and if it is showing RBC in urine routine also,
hmm,
when he is not complaining of hematuria,
hmm,
okay, that means the both the pathway
microscope.
are same. So then chances are very high that this blood is also coming from the urethra because it is mixed in urine also and also in
Urethra.
semen. Yeah. So if it is pure only in semen,
Urethra. Yes, sir.
then
Sperm.
it can be
Yes, sir.
from the seminal vesicle,
Oh,
prostatic like ducts, or
seminal vesicle.
can be from the
Ejaculatory duct.
ejaculatory.
Ejaculatory duct. Yes,
And
sir.
what are the causes, commonest causes?
So prostatitis, inflammation of uh, this seminal vesiculitis,
Yeah, so inflammation, yeah,
urethritis,
hypergranulation
prostatitis.
tissue. So one, yeah, and then tuberculosis,
Granulomatous,
then
Even in
meningitis.
granulomatous or
epididymoarthritis.
30.
Now, how often you have seen epidermal orchitis giving rise to hemospermia?
Really rarely, sir. I haven't.
Hemospermia means patient can see it.
Huh. And it is painful, so the patient comes with pain instead of hemospermia.
Yeah. Okay, fine. Go ahead. So these are the questions you will ask. Harshu, go ahead. Talk
Yes,
about
sir.
that.
So based on the timings, which indicates the site of origin, the initial hematuria would be more commonly arising from the urethra secondary to inflammation. Total hematuria could be from anywhere from bladder or upper tracts. Terminal hematuria, which occurs secondary to inflammation in the bladder, neck, trigone, or the prostatic urethra. Now, AUA has guidelines for microscopic hematuria.
Yeah, go ahead.
So, firstly, there is a question that why to risk stratify? Microscopic hematuria alone has a low cancer yield. The risk stratifications improves the test utility and avoids unnecessary invasive evaluations. So, in low risk, the criteria is men under 40 or women under 50, 3 to 10 RBC per high power field, never a smoker or less than 10 pack years, and no additional urothelial cancer risk factors. And the evaluation which we will do is a shared decision making regarding the evaluation options are a repeat urine analysis every 6 months, cystoscopy with a renal ultrasound, optional if the patient prefers early evaluation. So basically in low risk, a repeat urine analysis would be the way to go. For intermediate risk, the criteria is men aging with age of 40 to 59 years, women 50 to 59 years, 11 to 25 RBC per high power field, or 10 to 30 pack year smoker, and low risk patients who have persistent microscopic hematuria on the repeat analysis. In such patients, we would advise cystoscopy plus renal ultrasonography. And high risk patients are those above 60 or more than 25 RBC per high power field, more than 30 pack years, and history of gross hematuria or other strong risk factors. The evaluation would be best done by cystoscopy plus cross sectional, either CT urography or MR urography. In cases of gross hematuria, complete evaluation is necessitated in all the patients, and routine urine cytology and biomarkers are not recommended unless there is a special indication, such as there is a suspicion for CIS. These are the latest AUA guidelines, and this is one compiled table. Now, why not CT urography in the cases of low and intermediate risk? Because it may detect incidental findings which may lead to unnecessary workup. There is, although a requirement of cystoscopy for bladder mucosal lesions, in microscopic hematuria there is a low prevalence for malignancy. So many scans would yield a negative result. And ultrasound is a better alternative for scanning in the initial phases. So to avoid radiation exposure and over investigation, as well as the contrast nephrotoxicity, it is advisable to be reserved for high risk patients. So following this, we would move ahead to the differential diagnosis of hematuria.
Okay, fine. So Ashay,
Yes, sir.
so what can you just summarize in short? No, don't
Uh,
go in so much of details. Just what are the
so,
important things you have understood?
sir, I had one doubt. This is for asymptomatic microscopic hematuria, right? So if I know the cause, if the patient has a stone and
Yeah,
five RBCs, then I don't go for this workup. I do the other things, right?
yes,
So for asymptomatic microscopic hematuria, the risk stratification is low risk, intermediate risk, high risk. Low risk, we repeat the urine analysis after 6 months. In intermediate risk, we do cystoscopy and USG, and in high risk, we do CT urography as well as cystoscopy. And this is for
right.
detection of tumors, bladder carcinoma.
So almost they say that 5% of the patients may have malignancy. So that is why we have to be little vigilant whenever there is a high risk. Fine.
Yes, sir.
Okay. So, why you don't want to do CT IVP? I mean, plain IVP. What are the advantages of CT IVP over plain IVP?
Sir,
It will
in CT IVP,
Yeah,
I will get better anatomical delineation and small renal masses can be detected better, and also like uh, it gives a better definition for uh, for all pathologies of ureter and bladder tumors. So,
it will give the exact anatomical and functional detailing of the
uh,
lesion along with the
yes.
functional aspect of the kidney function, and it will give the extra renal anatomy also
Hmm.
for other organs.
so just start from the kidney right up to the bladder and outside the
Hmm.
bladder or outside the kidney. So, what about the parenchyma? What about the calyceal system? What about the pelvis? Then, what about the ureter? You understand? Then, when you
Yes.
go to the bladder, what about the muscle invasion or obstruction to the ureteric orifice? All these things and a small. So, all these things will be delineated in
CT.
CT
CTIVP,
tomography, which you will not be able to see. So, in a gross hematuria, what type of CT you will ask?
multiphasic triple contrast computer tomography, sir. Multiphasic, basically.
Multiphasic triple phase.
Dr. Ganesh Bakshi, please, just if you have got any suggestions on this.
नहीं सर ठीक है मतलब आई थिंक इट इज गोइंग फाइन मतलब सीटी स्कैन कन्वेंशनल एंड सीटीआई व्यू बेसिकली डायग्नोस्टिक एक्यूरेसी and I think CT has absolute great value or sensitivity for stones,
Hmm.
tumors, any lesions. So it gives us
Yeah,
structural everything. And probably even if there is either a benign cause or a malignant cause, it helps us to plan the further treatment very easily with respect to the
right.
structure of the urinary tract. So I think with the ease today, we have replaced conventional IVU with CT IVU.
I think so. He has, Dr. Ganesh Bakshi has given you more insight of this also, that benign as well as the we are thinking only of the malignancy, but benign as well as the malignant disease also can be diagnosed very easily, and you can also plan the action or your treatment plan also. So this is very important. Correct?
Yeah.
Fine. Harshi, go ahead.
So if during our times we used to do the regular IVUs, and if sometimes you would see a ureteral narrowing in that or something, and when we actually used to do scopies, there used to be nothing, or scopies, matlab cystoscopy and RGPs. So there used to be
Correct.
nothing. In whenever we have a doubt of a CT IVU, we can always have a 3D reconstruct. As such, the axial imaging is so clear that with a good radiologist, if you are sitting, you can measure the lumen anywhere. I mean, the structural clarity is fantastic with the CT. I think we'll go ahead.
Yeah, no, no. But what you are saying is right, because many times these questions are asked. Other two important thing is that you don't require much preparation in CT scan. While
Right.
if the preparation is not good, then CT, this thing, plain X-ray IVP will not show you all the criteria very clearly what you want to see on X-ray. So, and the last important thing is nowadays in the CT scan, the radiation is minimum compared to the multiple films you take in X-rays. So that is what our chief radiologist used to tell us, कि Gaurang, in plain CT, the radiation exposure in our machine is only 2 X-rays. And compared to CT IVP, compared to normal IVP, it is less than 50%. So the radiation hazard is also less. So these are the two important factors we have to remember. Yeah, Harshi, go ahead.
So here is a chart for differential diagnosis of hematuria. It could be urological causes or nephrological causes. For urological causes in the kidney, commonly we come across renal cell carcinoma, tumors, trauma, cyst, necrosis, stones. In renal pelvis could be calculus, UTUC, blood clots, papillary necrosis. Ureter would be ureteric calculi tumors, ureteric trauma or infections, urinary bladder carcinoma, cystitis, bladder stones, schistosomiasis or trauma. In males, prostate would be a cause for hematuria. It may be prostatitis, BPH, carcinoma, or post biopsy bleeding. In urethra, it could be urethritis, urethral strictures, trauma, and external meatus with meatal ulcer, balanitis, local trauma, or instrumentation may also present as a case of hematuria. And it is important to understand the nephrological causes as well. And in that, the glomerular causes are IgA nephropathy, post-streptococcal, glomerular nephritis, lupus nephritis, membranoproliferative Alport syndrome, thin membrane diseases. In the pelvis, it could be tubulointestinal nephritis, medullary sponge kidney, and hemorrhagic cystitis could be a presenting cause in patients who are taking cyclophosphamide.
Okay, go ahead.
Hematuria with painless presentation.
Go ahead, Harshu.
The causes may include malignancy, which includes bladder, renal, upper tract, urothelial tumors, or prostate cancers. Benign urological conditions such as BPH, radiation cystitis, schistosomiasis, polycystic kidney, papillary necrosis, anticoagulant related hematuria, or glomerular causes as described, or vascular causes such as nutcracker syndrome or AV malformations of the kidney. This is a mnemonic to remember the causes of painless hematuria. Commonly tumors, bladder, renal. B rapid, such as that expands as bladder cancer. R for rapid tumors. A anticoagulants and AV malformations. P for prostate diseases such as BP cancer. I is IgA nephropathy and related nephrological causes. And D is dysplastic kidney disease as well. Next, we move to hematuria with fever. Common causes include the upper tract infections such as acute pyelonephritis, pyonephrosis, abscesses, lower tract infections such as cystitis, prostatitis, urethritis, with infection, obstruction with infection such as infected urolithiasis. In specific infections such as genitourinary TB, schistosomiasis, renal inflammatory diseases such as acute glomerulonephritis, and severe systemic infections, that is sepsis with renal involvement. Now, cystitis has multiple types, which we have described in the next slide. So these are the expansion of the types of cystitis. It could be acute bacterial, chronic, interstitial cystitis, which is also called as a painful bladder syndrome, hemorrhagic cystitis, radiation cystitis, chemical cystitis, eosinophilic cystitis, emphysematous cystitis, follicular cystitis, polypoid cystitis, cystitis glandularis, tubercular cystitis, schistosomal cystitis, fungal or viral cystitis. Hematuria with pain. We can divide based on the type of pain. When it is colicky pain, it could be ureteric calculus, blood clot, colic, slough papilla. Loin or flank pain may be a cause for hematuria with pyelonephritis, renal infarction, polycystic kidney sometimes, renal vein thrombosis, and trauma. Suprapubic pain is found in cases of acute cystitis, bladder stone, clot retention, radiation and chemical cystitis. Perineal or pelvic pain in prostatitis and prostatic abscess, urethral burning or dysuria in urethritis or severe cystitis, and pain during micturition, terminal pain in cases of bladder stone, trigonal inflammation, or severe cystitis. Hematuria with clots, it could be upper tract in cases of renal cell carcinoma or UTUC, trauma, AV malformation, or severe infections. Lower tract causes can include bladder tumor, which is the most common cause, prostate cancer, severe cystitis, bladder trauma, or post instrumentation. And it could be other causes like anticoagulant therapy, radiation, or coagulopathy. A hematuria with clots is a bladder tumor unless otherwise specified.
Oh, okay. So in what type of clots you will get?
In the lower urinary tract, if it is from the bladder or from the prostate, we will get a amorphous kind of clot. If the clot is from the upper tracts, then we can get a vermiform or worm-like clots.
Okay, so the very, the question they usually ask is,
MRs.
in presence of
Uh,
hematuria, will you like to do cytology? And
No,
if you
sir.
want to do cytology, how will you do it?
In the presence of if there is active
so
hematuria,
centrifuge.
we will not do urine cytology because the sensitivity of the urine cytology will decrease due to the presence of lysed RBC. If however we want to do the urine cytology, we have to then confirm whether the active hematuria is going on or it has been stopped. If in the presence of active hematuria still we want to do it, then we have to centrifuge the specimen and discard the, and we have to take the we have to do the urine cytology from the supernatant of the urine segment.
Supernatural.
Arshia?
Yes, sir. Moving on, we have hematuria with trauma. So trauma could be blunt, penetrating accidental trauma or could be iatrogenic trauma. Common causes for renal trauma are renal contusion, perinephric hematoma involving the IC system or vascular injury, ureteric injury, which can occur while instrumentation or in other surgeries such as colorectal or pelvic gynec surgeries. Bladder trauma, a urethral trauma. Urethral trauma could be because of pelvic fracture and instrumentation, and post catheterization could be a cause, or it could be also related to post PCNL, RIRS, URS, TURP, TURBT, post radiation, or post renal biopsy.
Okay. So, Ankit, can
Yes.
you just classify the renal laceration, contusion, or renal trauma?
Sir, it is classified according to the AST grading system. Grade 1 is contusion or laceration. So it is contusion. Grade 2 is laceration less than 1 centimeter or laceration less than 1 centimeter. Grade 3 is laceration involving the renal parenchyma that is more than 1 centimeter or involving the pelvic lateral system. Grade 4, grade 4 is involving the
Grade
pelvic lateral
4 is
system. Grade 4 is involving the pelvic lateral system or urinoma formation. And grade 5 is
extras.
completely out or segmental renal artery involvement. Grade 5 is completely shattered kidney or avulsion of the renal hilum.
Okay. So, when you will suspect there is a renal trauma, number one, and how will you manage?
Sir, if in a, we will evaluate the patient in the in the emergency, and on examination, if there is gross hematuria and the patient is unstable, hemodynamically unstable, or in the presence of microscopic or in the presence of hypotension, and there is bruise and contusion over the flank area,
Mm.
or there is
So,
history of rapid acceleration or deceleration injury, sir.
so immediately what you will do?
Rib fracture. We will do a CT, sir, contrast CT.
Sitting.
If the
First of all,
patient
we
is stable,
will
then CT. Patient is away with stabilize the patient, resuscitate,
take, yes, sir.
admit and resuscitate the patient, and then proceed for evaluation.
So, before that, you can do even the bedside first emergency
One shot,
bedside
one shot,
ultrasonography also, no?
fast.
Fast sonography, yes, sir. Fast also will come to know.
Yeah, so immediately, at least whatever, if you see there is a lots of, shattered kidney or there is a hematoma or there is collection, okay, then after stabilization, the first thing you will do is to do CT. And before that, you like to know the creatinine also, correct?
Yes, sir.
Yes, sir.
Because you want to give the
Contrast.
contrast. So you want to know all these things.
Yes,
So the
sir.
bedside ultrasonography is very important. Gite sir, आपको कुछ anything you want to comment on this? Okay.
I think ठीक है sir. We'll go ahead.
Oh yeah. Yeah. Fine. Go ahead. So now, what are the types of bleeding you'll get in PCNL?
It can be venous bleeding, it can be arterial bleeding.
Okay. Then how will you manage?
If it is an arterial, if it is a venous bleeding, then placing a PCN and it will help through via tamponade effect. And if it is an arterial bleeding, then we have to fulgurate that bleeding site and via Bugby. And if
So
that is not
people have tried. All see it. Sometimes it becomes very difficult to know whether it is arterial bleeding or because it is bleeding from
Mm,
continuously from all the sides in PCNL. So it becomes very difficult. So the
Mm.
first thing is when the most important thing is if you are suspecting gross bleeding, best thing is to put the nephrostomy
Footnote.
mm,
and stabilize the
Appendage.
patient and come out.
mm,
Yes.
And
and clamp it,
okay,
clamp.
plan the procedure
Yeah.
with a different puncture. Now, number
Yes, sir.
one, when you are doing the puncture and you don't get a clear fluid and you get the blood, fine. And in spite of giving fluid from below, flushing it, still you are getting a blood, then you must not dilate it, remove that, and make another puncture. That is number one. Correct?
Yes, sir.
Yes.
Okay.
Yes, sir.
Second thing is, as I said, if you are suspecting there is a gross bleeding, stop PCNL. Third thing is now you have done the procedure and suddenly the patient's hemoglobin has dropped, BP is dropping, and patient has got hematuria. May not be immediately after 1 or 2 days, but maybe after 4 or 5 days, or maybe after 1 month. What you are suspecting?
Mm. Sir, I will
Secondary
suspect
infection,
pseudoaneurysm or
pseudoaneurysm or
AV fistula
fistula.
if there is
AV
significant HB
malformation.
drop.
So
Yes, sir. AV.
tell me the difference between these two.
Sir, pseudoaneurysm is a dilatation of the uh, artery
Ventisca.
without a true wall, and uh, it causes bleeding, it causes hematuria. And AV malformation is when in between the tract, the open end of the artery and vein, after
Communicate with
the
each other.
edema settles, they connect and they form a fistula between the artery and the vein, which also can cause bleeding.
But
So clinically,
pseudoaneurysm,
how can you judge?
Sir, it can be differentiated on CT and renal angiography or DSA.
with the
Clinically, I'm
presence of
asking
pseudo.
you. Yeah. Tell me.
Uh,
ठीक है, I think you should
Pseudo.
talk. You are correct. Go ahead.
Go ahead. So what will happen? What type of bleeding in pseudo and what type of bleeding in this thing, AV malformation?
Hmm. Sir, it will require angioembolization by
Both
interventional
both will
radiology.
require. Both will require.
गाड़ी फुल
Both
चले
will require.
कौन हो
Yes, sir.
Both will require.
क्या
Yes, sir.
But in pseudoaneurysm, there will be a sudden, intermittent, sudden gross hematuria.
Okay, sir.
While AV malformation, but please correct me, in AV malformation, there is usually, repeated or the continuous
intermittent.
hematuria. It will not stop.
Continuous and intermittent. Okay, sir.
Okay, fine.
Yes, sir.
Okay. So now post radiation. This is very important. How will you manage post radiation cystitis hematuria? Step by
Initially, we
step.
will.
Sir, initially we can try intravesical alum installation,
No,
1% alum
No,
sufficient.
no.
no.
Patient has come with the clots. Now, how will you
Sir,
manage?
now first I
In,
will admit, I will catheterize with a three-way
It
catheter,
will get
and
blocked.
uh, I will check the hemoglobin, transfuse the patient, and maintain his hemodynamics, and also give fluids and transfusion as per requirement. And for hematuria, I will first do a bladder washout, and then once it is clear, once the bladder is out, the clots uh, f- are out, then I will start continuous bladder irrigation,
But there is a active bleeding from some points in the bladder.
and
and
then
then if the bleeding does not stop after the initial supportive care, that is with irrigation, and then we will go for cystoscopy and clot evacuation along with fulguration of the visible bleeding
okay, sir.
vessels. The
Fine.
Okay.
So now you
Yes.
are agree. Anki, you have done it. You have
Yeah.
removed all the clots. You have seen inside there are multiple bleeding points. You have coagulated quite a lot of bladder wall in radiation cystitis. The capacity is also less, and it's quite friable. Okay.
Mm.
After 5 days, again patient has got bleed.
In that scenario, we will give an intravesical instillation of 1% LM. That is 5 gram of LM in 5 liter of normal saline. If uh, if if
50.
that too is not working, we will wait for 24 to 48 hours, because LM irrigation will take around 24 hours to work. So if after 48 hours again there is hematuria is continuing, then we will put the patient. Then we will, if we have the facility of hyperbaric oxygen, then
Hmm.
we will give the hyperbaric oxygen therapy. If we don't have that
How
facility,
many how many cycles?
sir, usually for it is 40 to 40, 35 to 30 to 45 cycles given over the
Yeah,
period
30
of
to 40. Yeah. Okay.
and
So,
if
Ankit,
yeah,
actually,
yeah,
what happens is if you are managing an acute scenario,
yes sir,
I don't think hyperbaric oxygen is a choice.
Mm.
Okay.
yes sir.
In acute scenario, you can't do something like hyperbaric oxygen. If you know that the patient is repeatedly having episodes of hematuria because of radiation cystitis, which are stopping in between, and there is no clot retention or clots in the bladder, that is the time when you go for hyperbaric
You
oxygen therapy.
okay,
It doesn't work otherwise.
yes sir.
And in acute situation, again, uh, you said about fulguration of the bladder. So radiation
So
cystitis bladders are typically very thin.
Hmm.
And
the chances of
unless
perforation.
fulguration is taken as a last resort. So if you have all
Okay.
the equipment, argon plasma coagulation is the answer in exam. Any
Okay,
normal
sir.
examiner like Uttam Mete, you tell this fulguration and he'll fail you. What you will achieve with fulguration is already the bladder is thin. You will go after that bleeder, and that causes immediately when you touch with a ball or a loop, TUR
Hmm.
loop, you are going to go deep.
Mm.
There's a great chance of perforation. There is a great chance of this hematuria temporarily stopping, restarting, and you will need to touch again at the same place.
Mm.
So the exact answer is argon plasma coagulation, which causes a
Okay.
very surface coagulation.
Okay, sir.
Yes, sir.
Any other measures?
Sir,
So
if the
if
bleeding is
LM doesn't
continuing,
work, we can try
See,
formalin.
practically, yes. I have also tried alum, but alum is not the first answer in exam. When the examiner asks you what else, it can be alum, it can be a
no
starting simple
profile.
thing as a tablet Tranexa, IV Tranexa, then
Hmm. Sir, but it is said keep the
EACA, something. All these things come later.
sir, but
Time-tested
it
things are cystoscopy, clot
yeah,
evacuation,
okay.
argon, angioembolization.
Physician
Hmm.
anterior branch of internal development.
Yeah, these are time-tested things and which are okay.
Sir, I have
Mm.
one query, sir. Sir, you have told about giving injection Tranexa, but
Giving what?
yeah, Tranexa, sir.
So Tranexa is not the
Yeah,
first thing. It is like
yeah.
Tranexa can be
But
as good as a placebo. You go on, you ask me.
Mm.
yes, sir, because in our institute, sir, we don't advise even to the other department. If the patient is in ICU and he is bleeding, then we always tell them not to give Tenexa. And we have seen that thing if the after giving Tenexa, the clots become very hard and it is very difficult to evacuate during the clot evacuation. We have to go with the loop and cut it. Then only they came out, sir.
I mean, I don't know. I mean, that is not my experience. I don't think any clot gets so hard that you can never get it out of the bladder. Number one. And number two, Tranexa, sometimes in common language, we feel that it is just like a placebo. It works or it doesn't work, really, we don't know. But it has some mechanism in stopping bleeding.
Okay.
Somebody had just put there, what about chlorophyll? So I guess the whole exam going batch should understand that the drug has been developed at BARC. It is still under trials. The initial trials with chlorophyll are already over, and it has been highly successful. So the active tablet available is Actosite. We use either 500 milligram or 750 milligram daily in patients who are suffering from radiation cystitis. And now the studies are going on where they are using it along with radiation and thinking that it might be overtly protective. So this Actosite or chlorophyll given every day has excellent results in these patients.
Okay.
So that was for everybody. Should we go ahead?
Yeah. But no, they have not completed the answer. No, if it is recurrent bleeding, then hyperbaric oxygen is okay. But otherwise, as you said very rightly, if it is a bleeding, then the embolization or
Angioembolization.
Selective
maybe very
angioembolization of the
rarely,
cystectomy, sir.
Cystectomy, urinary
and
diversion.
That's the
Version.
last resort.
yes. So we go very systematically, na? Okay,
Yes,
like a flow chart. If this actively
Hmm.
bleeding, not coming under control, then these are the thing. And say fulguration is like he said very rightly, Dr. Mate, and there are professors who are the examiner, and they are very, very much uh, strict about all these things. They are very practical. So you have to be very careful about that. Okay.
And anyone asks you, like Sir had asked you, patient is actively bleeding with radiation cystitis. So have a standard answer ready. I will assess the patient properly with vitals, some coagulation parameters, hemoglobin, वगैरह. First, I will resuscitate with 1, 2, 3, 4, which you mentioned here, there, and then come directly to what, as per priority, you will do. I will try to give a bladder wash and see something happening. Bladder wash fails, I'll take the patient, do a sonography in between, take the patient in OT, evacuate him. If the bleeding is absolutely less, I might not fulgurate at all. I might just put a three-way and keep irrigation running on. If that bleeding is there, I would, if available, prefer argon. Not available, dangerous thing, but just point coagulate. Can't do that repeatedly. Start the patient on Actosite today. Also can offer hyperbaric oxygen therapy. That's it.
What is the
Sir, sir,
sir?
what about formalin? Do we say
Yes, sir.
formalin in
Same
exam?
thing.
I think today we don't say no role.
No role.
The historically used like alum, no role today.
Fine. Okay, so please, all of you should know this answer perfectly.
How long
Don't
Actosite should be
hesitate.
given? Ideally, it is a chlorophyll plant-based supplement, can be given lifelong also. There is no inhibition. Like you
And
prescribe vitamins to a patient, which sometimes are not needed, but Actosite has done very well in radiation cystitis.
yeah,
It sometimes
and
makes the
along with
stool green, by the way, and the urine also gets a tinge of green.
fine.
Yeah, go on.
Correct. Okay. So now in just to go, suppose if you are doing RIRS and now there is suddenly bleeding. Now what you will do?
Mm. Sir, if I can
Ashay,
see the
you nowadays
process.
all of you are, I'm sure, with the
Yes, sir.
disposable RIRS. I think most of the residents are doing RIRS. Correct? There was a
Yes,
time when even the consultants were not doing RIRS. But now everyone is doing RIRS. So you also must have come across sometime cases where there is a severe bleeding. So now what you do?
Sir. So intra-op, I will see if there is visibility. If it is just a mucosal injury, then it will heal on its own. But otherwise, if there is no vision and I cannot see, then I will place a DJ stent and then abandon the procedure.
Embed
And
the
we have to.
procedure and what
And
you
we
will
have
do?
to.
Put a DJ stent and
And
abort the procedure and put Foley's and come out.
So what type of Foley's you put if there is active bleeding?
Sir,
A three-way 22 French
generally,
cat, 22 to 90, 24 French catheter, sir. Three-way.
So always,
Eh,
always better to keep, because we have seen in couple of cases that there may be a
uh,
clot retention, you
three-way.
know, and
Yes.
then wait, if the patient is
Hmm.
improving,
Yes, sir.
well and good. Okay, otherwise you might have to go again. Don't ship the patient.
Hmm.
Keep him in the OT,
Okay, sir.
14.
because there
Okay,
may be
sir.
sometimes so much of bleeding that there will be clots inside the bladder, and you will have to evacuate. So you might have to take the patient
Evacuate the
again.
clots.
And okay,
Yes, sir.
you pray God
Hmm.
that you don't come across this situation. But I'm 100% sure that in your practice, sometime you will come across this problem. So if there is a
Hmm.
really very active bleeding, don't move the patient after putting the catheter and all these things. Just wait.
Sir, if we are
Okay?
able to, sir, if we are able to visualize the bleeding as a pinpoint bleeder here and there in the mucosal wall, can we fulgurate, can we coagulate it with at that same time using laser?
See, all these things are very theoretical. The reason is because you are going with a very small scope. Your
Hmm.
vision is very much restricted. Plus,
Hmm.
there are multiple calluses in the kidney. Okay.
Hmm.
So it is not like cystoscopy where the cavity is much bigger, the scope is much bigger, and the you can really see the bleeding point either from the bladder or from the uh, prostate. Okay, here it
Hmm.
becomes very difficult. Theoretically, yes, but otherwise it becomes very difficult.
There are
So
Thank you,
if
times
sir.
that
vision
you
is there,
can
can we try?
coagulate. There are times in the kidney that you can coagulate, but you should be very, very clearly seeing the bleeder.
Yes, sir.
Hmm.
and
That's what I
a-
was saying.
and it is a little dangerous, because if you go deeper, the bleeding can worsen. So it requires
Hmm.
a lot of experience to do that. I have done once or twice coagulation in PCNL using a Bugby electrode, but laser, you have to understand really how to use the laser. You have to defocus the laser and use it. If you go and touch the vessel, it will keep on bleeding further.
And sir, what settings for
If you want to
coagulating
see,
vessels?
next time, I'll show you a video of how you can coagulate with laser. When we were doing RIRS, I was doing an infundibulotomy. At that time, it started bleeding. So, and it was a very difficult position because it was a lower calyx. So
Hmm.
I can show you that video next time. I will prepare it. I'll tell Harshiv to show you a short video. But in during trying to control bleeding with laser requires a lot of experience, and you have to defocus it and not fire the laser directly on the bleeder. Bugby
Okay, sir.
electrode is a little bit better. Even during PCNL, once or twice when I have seen a bleeder, I have coagulated. But it's dangerous because in PCNL you can go deeper and then it can lead to a catastrophe.
Hmm.
So best is to try and control it by putting a PCN or something. And in RIRS also you have to give it like 5 minutes time. If it's really a spurter, then you should try to control it.
Hmm.
Sir, what should be the setting of laser
So
during the fulguration of that
they
bleeding?
have a hemostasis mode. So you can go
Hmm.
in TFL they have a hemostasis mode. Otherwise you can do 110, one energy and 10
And
frequency.
and frequency. Okay,
Yeah.
sir.
If you go to hemostasis mode, just use the setting that starts 1 and 6. Maximum 110, not more than that. Basically, to control bleeding, you need more frequency. So all modes in lasers are basically all modes in the new machines are all long pulse width. The only mode with the short pulse width is the fragmentation mode. So that you should
Hmm.
remember. In laser settings, all modes are long pulse.
Long
The only mode which is short pulse is the fragmentation mode.
fragmentation. Okay, sir.
So in pulse width setting, you select the long mode, long pulse, and you use 110 frequency.
Sir, and about pressure, do we increase the pressure?
If you increase pressure, then your bleeding will stop. Now that is not the right way to do. In fact, never increase the pressure. You mean the irrigation pressure?
When
Irri-
is
so,
bleeding
sorry?
or decrease with in and then it will worsen. Do we
No, no. Irrigation
increase
should
or
be
decrease?
only irrigation should be only gravity. Don't increase the irrigation.
Okay. Hmm.
If you increase irrigation, you will not see the bleeding. If you decrease it, it will increase
Okay,
the
sir.
bleeding.
Hmm. Yes, sir. Okay.
Gaurang?
Thank you, sir.
Hello.
This is Dr. Sable. Can I add something?
Yes, please, please.
Basically, in RIRS, the bleeding is due to excess pressure generated by the system. So, first is one should decompress that. This happens more commonly whenever the system is congested and more it is dilated. So, at time it could be due to fornical rupture, and at time it could be due to actual renal rupture. So first is keeping the low pressure. One should keep the irrigation fluid as minimum as possible. It should be monitored actually. So if possible 20 to 30 with about 40 ml per minute should be the optimum fluid for use for. So if the bleeding is temporarily decreasing after putting a pressure, and it is once the irrigation is decreased, it is increasing, it is a danger sign. One should really stop at that time. Dr. Bakshi said tranexamic acid is likely to, in this situation, in this situation,
Have space or beds or anything, not that time. Space or second.
tranexamic acid do work in this situation, and one has to be vigilant. A second day sonography may be essential if the vital parameters are not keeping, or there is off and on hematuria. I know one case where the grossly hydronephrotic kidney had ruptured, and there was 2-liter hematoma in the retroperitoneum, which had sepsis, and the patient was lost at the end.
Yeah, I agree
Fornicial
with you.
rupture is a very important thing, which we are also telling while teaching about these new RIRS scoops, which have the pressure monitoring in the kidney. So actually, you have to use your clinical acumen that while using the pressure monitor on the RIRS scope monitor, you should not be thinking that pressure is normal and you keep on increasing the irrigation. If there is fornicial rupture, it will show low pressure in the kidney, but actually that is actually not low pressure. It is because the fornix is ruptured. So what sir is telling is very important, that you have
Hmm.
to always keep in mind that if there is a fornicial rupture, all the bleeding is happening outside. There
Yes,
can be
yes.
a
And
huge
second,
hematoma after RIRS also.
and second important thing, what he has said is also right. If there is a really hydronephrotic kidney, then there are chances that you may rupture the kidney because of the high pressure, and there will be a hematoma and the gross hematuria outside the kidney rather than inside. So I also have come across such cases. So that also you have to remember. Okay, so Ankit, now
Yes,
you are catheterizing the patient. Okay,
yes, sir.
and after that, patient has got lots of bleeding. What is your interpretation? And how will you go about?
So the bleeding is from the renal parenchyma. And, we
No, no,
will
no.
assess the
After catheterization.
in after RIRS, na, sir.
No, no, no.
Uh,
RIRS is
uh,
over.
Normal.
okay, okay, okay. Okay, if the patient is having hematuria, then we will.
Patient has come. I'll give example. Patient has gone to medical department. Okay, and
Yes.
they wanted to catheterize the patient, and after that, patient has got severe bleeding. Now, what is your interpretation? How will you go about?
Uh, so this is decompression hematuria. We will first assess the patient vitals, and we will take history regarding his if the patient is having a lower urinary tract symptoms apart from prior to the episode, and we will
They are saying that they put the catheter, few ml of urine came, and now there is a severe bleeding.
so then I will ask to the person who has put the catheter whether at the time of insertion there was any trauma, or he has felt some resistance while putting the catheter. If to rule out urethral injury.
So what has happened?
Maybe
There is a long-standing retention and there is a sudden release of the pressure, there may be a hematuria. Yes, that is when
decompression
there is
hematuria.
Decompression.
correct decompression. But uh, if the urine has not come, hardly 5 to 10 cc of urine has come, and after that, if there is a severe bleeding, that
Sir,
means what?
False
then there
passage
is a
or
balloon inflation in urethra.
in the balloon
Yes.
inflation in urethra, false passage, sir.
So now what you will do? How will you manage?
If the patient is stable, then I will take the patient to the OT and under cystoscopic guidance, I will put the catheter, sir.
Fine. But if he is not, he is in
And then,
ICU, he's on a ventilator.
Bedside flexible
bedside
cystoscopy.
flexible cystoscopy, and under the guide wire, we will put a catheter, sir, and give a perineal compression. And preferably, I want to place the three-way Foley's catheter and start give a perineal compression.
So your answers are both the answers are perfect. I agree with you. But little away from that, when all these things are not available, how will you manage?
And then I
You
will
can't
remove
take
the.
patient to, you can't take patient, okay, from
Yes.
ICU. Number one, you don't have, everyone doesn't have flexible cystoscope.
Sir, then
I will take out the catheter and put under the. I will try to put the. I will try to put another catheter under guide wire guidance.
Okay, so one
blind
answer is
guide
that
wire insertion.
you'll put a guide wire, and
Yes, sir.
usually if there is only because of this rupture, because of the inflation of
Balloon.
the balloon, there are very high chances guide wire will go into the bladder, and over that you will pass. So how will you pass the catheter over the guide wire?
Over a 24 or 26 gauge needle, I will put the. I will try to pass the catheter. I will.
Which needle you will take?
Pink
Sir,
needle.
a pink needle, 18 gauge, 18 to 20
18.
gauge.
18.
Only 18. 20 guide wire will not go. Okay.
Over the 20 gauge, yes, sir.
Yeah.
Yes, sir.
Fine. Or
if I
Tonsil tip catheter.
or over the introduce, sometime you can gentle, you can try over the introducer. Okay. And if the introducer or dilator will go very smoothly, then you can put. These are the only practical things I'm telling you. If Dr. Maheshwari is there, he will definitely will not like to, give you that give this answer. This is only practical tips we are giving you.
Yes,
Okay. Fine. Dr. Sable, you want to ask any questions about this?
I just have one more suggestion. If the patient is in ICU, is on anticoagulants or antiplatelets, then they are going to come into picture. If the balloon has been inflated in the urethra, at times it really bleeds significantly. So in that cases, if there is a distended bladder, they should aspirate it with needle at that point of time, just to relieve the distension. Quite often, it is likely that the
Or put the
urine is suprapubic aspiration, needle aspiration, or whatever, and keep a nice pressure, perineal pressure dressing, something equivalent to our urethroplasty dressing, so that the bleeding will be taken care of. If somebody has experience of putting a scope after a balloon inflating in the urethra, it is a ghastly rupture, and usually it is just distal to a narrowing, maybe a stricture or something. So even the guide wire is also likely to come, and usually the wide rupture.
False
So the
passage.
guide wire is also likely to go into the
Coil.
same, and you are just going to coil your catheter there. So attempting catheter blindly per urethral after previous rupture is not so advisable. If somebody had put in a catheter, it is not draining, and you are palpating a balloon in the perineum, temporarily avoid to deflate that at that point of time. The minute you deflate it, there will be sizable bleeding per urethra, because now it has all the spongiosum is already ruptured. So in a emergency, you drain out the bladder, make the patient comfortable, and at appropriate time, if you have take some time, work it up for taking to the OT, do it under vision, or trocar SPC would be an answer if the patient is not on a very heavy anticoagulants or antiplatelets.
Just a caution, whenever we discuss, we always remind you that if you are going to do SPC in the casualty, use your bladder scan to see that there is no bladder mass. Otherwise, if you put SPC, it is going for.
Fine. Okay. Harshu, go ahead.
Yes, sir. Next, we move on to the nephrological causes along with hematuria, such as renal failure, rapidly progressive glomerulonephritis or vasculitis and myeloma could be a cause. Hematuria with proteinuria, IgA nephropathy, post-streptococcal or lupus nephritis or Alport syndrome. Hematuria with hypertension could be due to glomerulonephritis, polycystic kidney or renal artery stenosis. Hematuria in a patient with anticoagulation, we have to be careful that is it because of over anticoagulation or could there be an underlying malignancy. Hematuria with edema in nephritic syndrome with recent URTI could indicate IgA nephropathy or post-streptococcal. So that is differentiated on the basis of duration when the patient has developed URTI and then hematuria. Hematuria with LUTS or dysuria could be due to UTI, BPH or bladder tumor. Hematuria with exercise induced or it could be due to exercise induced hematuria or nutcracker syndrome. And with if it is associated with smoking or weight loss, then it could be urethral carcinoma, renal cell carcinoma, or genitourinary tuberculosis. This is a chart given in Campbell's 13th edition about how to go ahead with a patient presenting with microscopic hematuria. And we have already discussed it, the blue portion, in our AUA guideline section. So this is just something that has been updated in the urology Campbell as well, which is required to be understood.
Yeah. Go ahead.
So now we are moving on to touch up on the topic of fever. It is a very common presenting feature for many patients, and we have to just understand the types of fever. The continuous is when there is fluctuation of less than 1 degree centigrade. The remittent fever is when there is fluctuation of more than 1 degree centigrade but never reaches the baseline. Intermittent is when there is fluctuation but it reaches the baseline. Step ladder is gradual rising, which there is gradual rise of temperature daily and commonly found in enteric fever. Pale Epstein fever is cyclical fever, which has 3 to 10 days of fever, alternating with days of afebrile period. It is classical example of Hodgkin's lymphoma. Relapsing fever is febrile episodes separated by days of apyrexia. So urological impact of systemic comorbidities. So we are going ahead with the first topic, that is diabetes mellitus.
Yeah. So why we are asking this? Because in last exam, when couple of examiners, they were asking, okay, so what is the effect of diabetes in urology or diseases or in urology? So Ankit, can you tell
Yes, sir.
us?
Yes, sir. Diabetes mellitus uncontrolled diabetes mellitus can lead to diabetic cystopathy due to autonomic neuropathy. It may also lead to
Start from
which,
either start from below up or start
Kidney.
from above down.
okay, sir. Coming from going from upside down, sir. In the kidney, it may cause acute pyelonephritis or recurrent pyelonephritis. It may be a cause of papillary necrosis. It may cause it may be a cause due to recurrent pyelonephritis, or it may lead to chronic kidney disease and
And diabetic nephropathy.
diabetic nephropathy, which can lead to chronic kidney disease. And coming on to bladder, it may cause the diabetic cystopathy due to autonomic neuropathy, which may lead to the increased bladder capacity with decreased diffuser activity, which may lead to obstructive LUTs and overflow incontinence.
And
Also ED,
And
erectile
yes, sir,
dysfunction,
erectile dysfunction, sir.
can
sexual
cause
dysfunction.
prostatitis, prostatic abscess,
Yes,
Hmm.
erectile
yes,
dysfunction,
dysfunction.
balanitis,
This zoonotic,
venonovasculitis,
yes,
phimosis.
yes,
So start from above. You can say, okay, it can cause renal abscess, it can cause pyelonephritis, renal abscess, perinephric abscess. Correct. Okay.
Hmm.
yes, sir.
Emphysematous pyelonephritis. pyonephrosis, papillary necrosis, obstruction, ureteric. It can also give rise to the stone formation, then come down to bladder. So, see, this is what examiner wants. They want you to be fluent and enumerate almost all the causes. So that is very important. Okay, Harshi, go ahead. Second important thing
Yes.
is which are the drugs which are used in diabetes? They interfere with our urological diseases.
Sir, SGLT2 inhibitor may cause glucosuria, which can lead to recurrent UTI. And although not proven, pioglitazone has been implicated in causing CA bladder, sir.
Yes.
And met and
Hmm.
metformin can lead to lactic acidosis. So if we are planning for any CT scan in a
So,
diabetic
hmm.
patient, it has to be withheld for 12 hours
Contrast.
before.
Yeah, you want to do the contrast enhance, correct?
Yes, sir.
Mm.
And it should be withheld for next 48 hours after giving the contrast.
Okay, fine. Harshi, go ahead.
The pathophysiology includes the diabetic autonomic neuropathy, wherein the damage to parasympathetic and sympathetic nerves leads to diabetic cystopathy and impaired bladder sensation and detrusor contractility. Microangiopathy due to diabetes, it leads to thickening of the capillary basement membranes, which reduces the blood supply. Immune dysfunction, it reduces the neutrophil functions and impaired chemotaxis and phagocytosis, because of which the susceptibility to infection is increased. Glycosuria increases the glucose in urine, which promotes the bacterial growth. And metabolic changes, which chronic hyperglycemia damages the glomeruli and the tubules. The diseases found in urology which are linked to diabetes commonly are diabetic cystopathy, which is the most common complication of diabetes. And it is because of the autonomic neuropathy. There is increased bladder capacity, increased post-void residue, weak stream retention, overflow incontinence. And management is timed voiding, double voiding, CIC, and treatment of the infections. Urinary tract infection risk is increased, most commonly E. coli, Klebsiella, Proteus, Enterococcus, and Candida. Similarly, there could be a higher degree of infection due to gas-forming organisms, which may lead to emphysematous infections, emphysematous cystitis, emphysematous pyelonephritis, and sexual dysfunction such as erectile dysfunction, ejaculatory dysfunction, diabetic nephropathy because of glomerular basement membrane thickening and mesangial expansion. So leads to proteinuria and CKD. Foreigners gangrene, which is a necrotizing perineal infection, and emergency debridement would be required. And there is association of bladder and renal cancer with diabetes as well. Medications, metformin, one of the most commonly used medicines. It is contraindicated in advanced CKDs. There is a risk of lactic acidosis. And there is also an implication in stopping it before the iodinated contrast studies. And we can restart it after 48 hours if the renal function is stable. SGLT2 inhibitors such as dapagliflozin, empagliflozin, and canagliflozin, they cause osmotic diuresis due to glycosuria, and this leads to increased genital fungal and bacterial infections and increases the UTI risk. Although in diabetic nephropathy, it has shown to have a renoprotective effect. Pioglitazone thiazolidine diones, there is a controversial role of its association with bladder cancer. So we usually tend to avoid it in the patients with history of bladder cancer or unexplained hematuria. Sulfonylureas have a risk of prolonged hypoglycemia in CKD. Insulin has a positive role in managing severe infections such as emphysematous pyelonephritis, Fourier's gangrene. So we usually prefer to have a strict glycemic control with insulin and stopping the OHS whenever a patient is presenting with severe disease. So now we have hypertension linked to the urology. Shall I go ahead, sir?
Go ahead, Harshif. Harshit, go ahead.
So, pathophysiology of urological complications in hypertension. Hypertension causes hypertensive nephrosclerosis. So, the hyaline arteriosclerosis, which leads to thickening of the vessels. Now, with thick vessels, the blood flow is compromised, and which leads to glomerulosclerosis, tubular atrophy, and CKD. With increased blood pressure, the the renin-angiotensin-aldosterone system is activated, and it causes vasoconstriction as well as sodium and water retention. So there is persistent renal injury, and hypertension. It aggravates the hypertension cycle. Endothelial dysfunction. Because of chronic vascular damage, there is a decreased nitric oxide and impaired vasodilation, which reduces the penile blood flow and can lead to vasculogenic erectile dysfunction. Accelerated atherosclerosis, hypertension promotes arterial plaque formation, which can lead to renal ischemia, and it can lead to CKD. Microvascular damage, small vessels are affected in the renal and penile vasculature, which again leads to CKD and erectile dysfunctions. So common causes: hypertension, heart failure, atherosclerosis, leads to reduced blood flow and endothelial dysfunction, and it can also causes uh, prostatic hyperplasia, erectile dysfunction, and overactive bladder syndrome. Neurological and neurodegenerative diseases such as Parkinson's, multiple sclerosis, spinal cord injury, and stroke. So, disrupted neural control, which interferes with the central and peripheral nervous system regulation of the micturition pathway. And the other mechanism is detrusor sphincter dyssynergia, which leads to the lack of coordination between the bladder contraction and the sphincter relaxation. So, neurogenic lower urinary tract dysfunction, detrusor overactivity, and urinary retention are commonly found urological diseases associated with neurological impairment. Other systemic conditions to be considered are CKD, OSA, chronic obstructive pulmonary diseases. So all these alter the physiology in a way that the fluid electrolyte balance is disturbed and the intra-abdominal pressure is increased. So this leads to nocturia, nocturnal polyuria, stress incontinence, and urolithiasis. We have the drugs commonly found to be associated, the drugs which can cause complications which can present into the urological scenario. So the hemorrhagic and bleeding disorders can be caused by anticoagulants, antiplatelets, thrombolytics, and chemotherapy, such as cyclophosphamide, ifosfamide. Hemorrhagic cystitis is caused by pelvic radiotherapy, chemotherapy, high dose KSAIDs. So with the mechanism of urothelial toxicity. Kidney injury and metabolic issues are caused by following drugs: nephrotoxic drugs such as contrast media, NSAIDs, aminoglycosides, vancomycin, amphotericin B, cisplatin, tenofovir. Polyuria and glycosuria is caused by SGLT2 inhibitors, lithium, and diuretics. Papillary necrosis is found in patients taking NSAIDs, diabetics, uncontrolled diabetics, sickle cell triggers, and rifampicin rarely. Interstitial nephritis is found in patients taking penicillin, cephalosporin, NSAIDs, PPIs, rifampicin. SIDH is associated with the intake of SSRIs, carbamazepine, cyclophosphamates. Bladder dysfunction or retention. So retention causing drugs are oxybutynin, atropine, TCAs, which are anticholinergics, sympathomimetics such as pseudoephedrine, phenylephrine, opioids such as morphine, tramadol, antipsychotics such as haloperidol, clozapine, benzodiazepines, rare, detrusor inhibition, or increase the outlet tone. So that is the mechanism by which they cause urinary retention. Many times in young patients presenting with urinary retention, we are not able to find any urological or anatomical cause. Then we can look forward to antipsychotics and antidepressant therapy. We have to ask for antidepressant and antipsychotic therapies, which people do not disclose as easily. Obstruction worsening drugs could be alpha agonists and such as decongestants, anticholinergics, calcium channel blockers, which decrease the detrusor contractibility, and baclofen. Neurogenic bladder dysfunction is caused by antipsychotics, anti-epileptics, and chemotherapy, vincristine. Sexual and reproductive health are affected by the following drugs. The erectile dysfunction can be caused by beta blockers, SSRIs, spironolactone, finasteride, and thiazides. Ejaculatory dysfunction can be caused by tamsulosin, silodosin, and SSRIs. Testicular toxicity or infertility can be caused by chemotherapy agents, cyclophosphamide, cisplatin, anabolic steroids, and testosterone abuse. Other significant adverse effects is stone formation by indinavir stone, topiramate, acetazolamide, triamterene, and sulfonamides. Sterile pyuria is found in patients taking NSAIDs, regular antibiotic therapy, interstitial nephritis drugs. Pseudohematuria by rifampicin, phenoxypyridine, metronidazole, or beetroot, which may mimic it. PSA can be affected by the finasteride and dutasteride or testosterone therapy. And UTI risk is increased by SGLT2 inhibitors, immunosuppressants, steroids, and chemotherapy. So by this, we have completed with the symptomatology. And the history part, we have to ask for certain other relevant history, which may include past surgical history, symptoms which may be found in metastasis, and symptoms which may be found in renal failure. So questions to be asked in past surgical history.
So how you are going to ask such history, Ashray?
Sir, in past surgical history, I will ask according to chronology which surgery took place first and ask for the operative notes if it is available, and then proceed.
History of any instrumentation or history of any urethral manipulation.
Mhm.
History of any stone disease surgery in
Or
the
any
past or any.
endourological or open intervention.
Okay. Then, so what are the relevant histories
Sir, so
usually come
history of
across?
endourological intervention, if a patient is presenting with LUTs with history of endourological intervention, then I will suspect a stricture, urethral stricture.
So the mainly
And
mainly it is either any other urological surgeries earlier. Second is a gynec, and third
gynec.
is a pelvic any other pelvic surgery. These are the most common, which can
So,
cause a secondary problem with the urological system. Correct? Okay.
yes,
Now,
sir.
patient, you want to describe, want to ask about the history of CKD or end-stage renal disease. So, how will you ask?
History of decreased urine output, facial puffiness, lower limb edema, and
Breathlessness.
breath, breathlessness.
And for the metastasis?
History of shortness of breath,
Loss of weight, loss of
loss of
appetite,
appetite, yes, bone pain, jaundice.
bone pain, jaundice.
Okay, Harshit, just show them and go ahead.
So in past surgical history, we have broadly divided into the symptoms, history related to previous surgery, the complications of any previous surgery, any history of instrumentation, or patient has having taken any radiation therapy. Previous history, abdominal surgery, pelvic surgery, urological various surgeries, or gynecological surgery as well are of urological consequences. Complications to the prior surgery could be urinary leak post-operative or fistula symptoms or scar-related obstruction, or could be instrumentation history via ureteroscopy, stenting, dialysis catheters, catheterizations. Radiation history, pelvic radiation could be a cause for ureteric obstruction or radiation cystitis fibrosis. Moving on to the symptoms in metastasis. So we have a mnemonic called "We all feel nervous before long cases." So W is for weight loss, A anorexia, F fatigue and night sweats or fever, B bony symptoms, L is lung, liver, lymph node symptoms, and C is for brain, cranial symptoms. To expand these, we have divided into constitutional symptoms commonly found in a patient with metastasis, which may be unintentional weight loss, loss of appetite, fatigue, malaise, low-grade fever, night sweats, liver metastasis, which can cause upper quadrant pain, right side, abdominal fullness, jaundice, and ascites. Lung metastasis symptoms could include chronic cough, cyphoptesis, and dyspnea. Brain metastasis symptoms, headache, vomiting, seizure, altered sensorium, focal neurological deficits, lymphatic spread to neck swelling, axillary nodes, and inguinal swellings. Bone metastasis, persistent pain, bone pain, persistent back pain, pathological fractures, difficulty in walking, limb weaknesses, spinal cord compression symptoms. Symptoms in renal failure. So it could be divided into the urinary symptoms, fluid overload, uremic symptoms, electrolyte disturbances, and the clues. Urinary symptoms are oliguria, anuria, foamy urine, hematuria, nocturia. Fluid overload symptoms such as pedal edema, periorbital puffiness, shortness of breath, orthopnea. Uremic symptoms such as nausea, vomiting, metallic taste, pruritus, confusion, hiccups. Electrolyte disturbance, muscle weakness, palpitation, muscle cramps. And clues to a CKD, a long-standing diabetes, history of hypertension, history of recurrent UTI, history of kidney stones, history of long-term analgesic use. Next, we are moving on to a small slide on the indications for dialysis.
So, Ashay,
Yes, sir.
can you just tell us when you will do dialysis? Apart from regular, when the patient has got the end-stage renal disease and he is
Hmm.
advised to undergo dialysis is a different thing. But apart from
Hmm.
that, which other conditions?
Sir, so in our uh, perspective, if a patient presents with bilateral obstructive uropathy like bilateral obstructive ureter calculus or obstructing calculus in a solitary kidney, and if the patient is in anuria or severe oliguria,
A.
and
So you
for
are saying A.
stabilization,
No, number one is A. So AEIOU. Okay. So A is anuria or acidosis, severe
anuria,
acidosis.
yes,
E
sir.
is,
Is
what do you mean by E?
Encephalopathy, sir.
edema, encapsulation.
Severe electrolyte imbalance like
Mm,
hyperkalemia.
Okay.
Then third will
Mm,
be
mm, so I don't know, sir.
I. IOU. Severe infection. O is
Infection.
return or fluid overload, ingestion of toxins. Basically,
Hmm.
I is
Okay.
infection and ingestion of toxins. O is fluid overload,
Fluid
and U
overload.
is uremia.
urine.
Uremia. Okay.
Okay, so this is very easy to
Yes, sir.
remember. A
Yes, yes.
E I O U.
Yes, sir.
Okay,
Hmm.
fine. Harshu, go ahead.
So now we have a short section on pediatric cases. What all to ask
So,
in
okay,
pediatric?
before we start, I think at least let them ask that in pediatric cases, what are the important questions that you will ask?
So first of all, from informant, chief complaints from the
So, who
informant,
will be the informant?
mother or
Ideally, should be
whoever
mother.
guardian.
Guardian, whoever is present that time, correct? But the best is
Yes, sir.
who? Mother.
Mother.
Best is mother.
Mother. Yes, sir.
Okay, fine. Okay. So, what are the questions you will ask? The child is 1 year old.
Sir, so the according to the chief complaint, we will proceed.
Usually, what are the
We'll
complaints they
ask the
will say?
mother.
Most of
If
them they will come
hematuria,
with
uh,
pain abdomen, hematuria,
Hematuria is
and
the commonest. You have come up
no,
with
sir.
it.
patient
Pain abdomen,
patient
lung
cries during micturition.
micturition, phimosis.
Mhm. Huh.
Come on, go
Um,
systematically. Either you say what are the
Mm.
commonest you have seen in your OPD, or
Mm.
when the patient is admitted.
Flying pain,
crying during micturition.
flying pain,
Okay.
passing urine from the under surface of the penis, then
Okay.
ballooning of the prepuce,
Okay.
then weak stream along with the severe constipation,
Hmm.
then discharge from the umbilicus,
Hmm.
and
Continuous
per
dribbling of urine.
continuous dribbling of urine, especially in female baby. Then
So they never get infection, na? No fever.
they get
Fever.
So
recurrent
commonest is
UTI,
what?
recurrent
Commonest is
UTI.
what?
Fever.
All these are very common, or infection is very common.
Infection and flank
Presenting
pain, sir.
Infection.
by 1 year old child, how he is going to say?
Hmm. Sir, he will have fever and he cries during micturition, so we can suspect urinary tract
Yeah,
infection.
yes, and the passing of urine from the undersurface of the penis or the
Yes.
cordy. These are the commonest you come across.
Yes, sir.
Okay. So once you elaborate this history, now systematically, how will you go? What are the other things you will ask?
Sir, then we will ask for
Antenatal.
in 1 year old we will ask for antenatal history. We'll ask for the papers, any ultrasound reports and blood reports and clinical notes during her antenatal visits, and
Then,
ask if the mother had any complications during pregnancy. Did she have uh, gestational diabetes or any other significant findings in her ultrasounds?
History of intrauterine IVF, basically, sir.
okay, fine.
Then his
Harshit. Okay. Then what else? Just finish it off. Then Harshit will tell you everything. How systematically to go.
Then, sir,
then we will
then
take
during birth, there were any complications? Was the baby kept
Yes.
in the NICU? Then, how is the baby developmentally? Then also,
Yeah.
then
immunization
other
history
vaccination history, immunization history.
and developmental history of the baby.
Hmm.
Fine. Okay. Harshit,
Mhm.
go ahead. Continue.
Yes, sir. So, in pediatric cases, presenting complaint usually by a parent or attendant or guardian. Commonly found complaints are poor urinary stream, dribbling, recurrent UTI, abdominal mass, incontinence, enuresis, scrotal swelling, hematuria, or crying during micturition and failure to thrive. Antenatal history, which it can be divided into maternal factors, maternal illness such as diabetes, hypertension, preeclampsia, or torch infections, drug exposure such as ACE inhibitors, antiepileptics, or teratogenic drugs, maternal oligohydramnios, polyhydramnios, radiation toxin exposure, consanguinity, family history of congenital urological anomalies or polycystic kidney diseases, fetal factors. So the antenatal ultrasound findings showing hydronephrosis, hydroureter, dilated bladder or cystic kidney or absent kidney, amniotic fluid status, oligohydramnios, which can indicate a severe urinary tract obstruction, fetal bladder anomalies such posterior urethral valves, which can present as a persistently distended bladder, timing of detection, early detection leads
Obstruction.
which indicates a more severe congenital anomaly. Associated anomalies could be present, such as vitral association, neurotube defects, and antenatal interventions should also be taken into consideration.
So, Ankit,
Yes, sir.
when when you are talking about ultrasonography and hydronephrosis, then what are the gradings as per the International Fetal Society? You know anything about that?
Yes, so through grading system and UDT grading system, sir. In UDT grading system, it has been divided into A1, A2, and A3, depending upon the anterior posterior diameter of the renal pelvis and then appearance of the renal parenchyma, thickness of the renal parenchyma, then the status of the ureter, the status of the bladder, along with the amniotic fluid, whether there is oligohydramnios, normal amniotic fluid content, or polyhydramnios. Then, depending upon the SUFU grading, it has been divided into 4 grades of the hydronephrosis. Grade 1, where there is mild splitting of the renal sinuses. In grade 2, there is dilatation of the major calyces. In grade 3, there is dilatation of the minor calyces. And in grade 4, there is thinning of the renal parenchyma.
And the size of the pelvis?
The size of the pelvis depend upon in the second trimester. If the size of the pelvis is between 7 to 10 centimeter. For
4 to 7.
4 to 7
Mm.
in first trimester, 7
7 to
7 to 10
10 more
in
than.
second trimester, and more than 15 in third trimester.
Means what?
So
Mild,
it helps to divide it into mild, intermediate, and
severe.
severe risk of antenatal hydronephrosis. Accordingly, depending upon the low risk or intermediate or high risk, we have to evaluate the patient postnatally.
Okay, fine. So after birth, when you'll do creatinine, when you'll do ultrasonography, and
Sir,
why?
after
Ultrasound after 48
48
hours.
hours.
48 hours, what you will do?
Sir,
Ultrasound.
we ultrasonography.
Ultrasonography or creatinine?
Ultrasonography.
Ultrasonography, sir.
Why you don't do in first 48 hours?
Sir, intravascular dehydration is there. So,
Mm.
So it will not give, there will
Dehydration.
not be any
Correct finding.
proper unit formations, you will
False
not get a
negative.
proper, correct. So
yes, sir.
ultrasonography should be withheld, they said at least for 7 days, because first few days child will get dehydrated. The same way, the first 48 hours, maternal creatinine is will be shown in the blood.
Patient.
So you will not get the right report. So only after 48 hours you should ask for the creatinine. Okay,
Yes, sir.
Yes, sir.
fine. Dr. Gite, Dr. Sable, you want to ask any question?
One of the important history is, especially in urology, we should be bothered about history of recurrent stone disease.
Okay.
Because which is a very common, and any history of stone, any surgery for stones, both of them are going to affect in a surgical history in the past history.
Yeah,
Okay.
fine. Okay, Harsh, go ahead.
Yes, sir. This is the UTD A and P classification as described. Now, the other important history is birth and delivery history. Full term or preterm birth, mode of delivery, is it LSCS or vaginal, birth weight, then whether post delivery NICU stay was there, delayed cry, catheterization at birth, or meconium delay. All these histories are important to for neurogenic bladder suspicion, spinal dysraphism, or hypoxic injuries. Developmental milestones. Motor milestones are delayed or walking delayed, toilet training delayed, regression of bladder control. So these are to be considered in cases of neurogenic bladder. Another important history to be taken in a pediatric case is a vaccination history. Is it up to date? Because BCG, if it is given, then there is a TB risk. Recurrent infections despite vaccinations. Urinary symptoms. The stream should be assessed. It is strong or weak, straining, intermittency, dribbling, daytime wetting, nighttime bedwetting, holding maneuvers, and crying while passing urine. Along with it, the bowel history is also important for looking for constipation, fecal soiling, or stool frequency, because constipation is strongly associated with dysfunctional voiding, recurrent UTI, and enuresis. History of infection. Patient with recurrent fever, UTI confirmed by culture, hospital admissions, antibiotic prophylaxis. Was there any breakthrough infection? So the definition of breakthrough infection. It is a symptomatic UTI that occurs despite the patient receiving continuous antibiotic prophylaxis. The common causes for a breakthrough infection is antibiotic resistant bacteria, non-compliance with the prophylaxis, underlying urinary abnormalities such as VUR or obstruction, and voiding this we complete the pediatric case important points of the pediatric case. We
Okay.
have a short slides on genes of urological significance next.
Okay. Just before this, I want to ask them just important thing. What are the investigations that you will ask in children?
The renal ultrasonography will be the go through investigation in children. It will tell us more or less everything about the baby condition. And if needed, if we have seen anything, any hydroureter nephrosis or anything of significance, then we can plan for VCUG or DMS, renal scintigraphy.
Fine. So always remember that if you are suspecting pelvic junction obstruction on ultrasonography, you will like to do
DMS
DTPA renal scan, and if there are
DTPA.
scarring, then DMSA, okay, the renal scan, correct?
Yes, sir.
Yes, sir.
And if you are suspecting that if there is a recurrent infection, and if there is a hydroureter hydronephrosis, and you are suspecting
VUR.
reflux,
VUR,
then
corticosteroid. Then VCUG will be the
VCUG and DMSA.
yeah, usually CT scan is not done unless and until you are suspecting
renal
anatomical
abnormalities like
congenital.
yeah, congenital
Also,
anatomical anomalies, and you want to establish that. Okay,
Yes, sir.
so that is very important. Fine. And whenever you are doing in children, whenever you are doing the renal scintigraphy, always drain the bladder. It's very important.
Archie was
Okay.
saying that we have to ask about urinary stream. So in children, how do you assess the stream? If the baby is small, in neonatal or infant, how will you assess stream? Simple. When the baby is lying down on the bed, you have to ask mother whether it's a projectile stream. So it comes on the mother.
Mother. Okay.
That's how you assess the stream, whether it's projectile or not.
Okay.
Fine. So now this is the last slide, which we have requested them to make it, because all of you please remember these things and always keep it with you. So every once in a week you must know about the genes, read it about, just remember it, and the syndromes, because these are the things you will always forget.
Some important ones which are commonly asked, at least those you should know by heart. Like ADPKD, ARPKD, RCC, papillary RCC, Wilms tumor. These are common ones. Okay.
Yes,
Sure,
sir.
Harshi.
Arshif, show
Yes,
them.
sir. So some of the tumor related genes which are commonly asked are VHL gene on 3p25 for renal cell clear cell carcinoma, MET in 7q31 for hereditary papillary RCC, FH gene in 1q43 for papillary RCC. Then we have a WT1 gene on 11p13 for Wilms tumor, TP53 17p13 for anaplastic Wilms tumor, FGFR3 gene on 4p16 for low-grade papillary bladder cancers. Muscle invasive is a gene implicated in muscle invasive bladder tumor is RB1 gene on 13q14. TMPRSS2 a gene on 21q22 is important in management of prostate cancer.
And BRCA1, BRCA2 also familial prostate
BRCA2.
cancer and aggressive prostate cancer.
Yeah. So this chart, please, all of you should have, and always keep it with you. I think you can keep it in your mobile always, and whenever you get a time, just go through it and always remember it.
Sir, I have
Fine.
found that video on that bleeding of RIRS.
Okay.
You want, sir, few seconds is there, I can show
Yes,
it.
yes, yes. Just
I'll just share
is
my
it?
screen.
Yeah, 1 minute. It is over now, correct, Harshil?
Sir, we have a few genes on the congenital disorders and endocrine stone related,
Uh-huh.
which we can just have. Excuse me. So PKD1 gene on
Can
16.
we get the slides? Okay.
Yeah, it will be shared, no?
Hmm. Hmm.
Can we
Okay.
get this slide
So
on the group, sir?
yeah,
Yeah.
put
Gene
this
slide.
those 3 4 important slides. You can put it on a group. Huh?
Thank you,
Fine.
sir.
Okay. Now Dr. Hiren Sodha will show you.
Yeah.
Harshu and
I'll see.
Rahul, you have done excellent job. Both of you, they have really
Yes, sir.
worked hard on this, So I must thank them and congratulate them the way they have presented, because it will make your life very easy. All those who are exam going, or those who are, now going to start their journey in urology, for them this uh, presentation is really of a great help. Okay, Hiren,
Yes, sir.
Gaurang,
I'm sharing the
yeah,
screen,
Gaurang,
bolo.
sir.
Yes, yes, Dr. Sable.
just before moving to Hiren's this thing video, I
Yeah,
will just elaborate the same point what Hiren said. A projectile stream, urine stream in a newborn practically rules out a posterior urethral wall. So
Yes,
the
sir.
student should definitely remember about this. If the child, a newborn child, infant, has really had a projectile stream and passed urine on somebody else in a projectile fashion, that practically rules out of PU walls. In
yes,
a PU wall, is the
yeah,
I think sir's voice was breaking because he's traveling. But
yeah,
what
he's
sir has
coming.
told is the very important thing. And examiner will ask you, how did you assess this stream? What question did you ask the mother? That time you have to tell that I asked whether it is projectile or not. So that is a common question asked, that how did you assess the stream? The child is so small, he can't tell you whether he had a good stream or not. So then you have to say that I asked the mother whether it came on the face or when the child passes urine.
Yeah, Hiren, you can show your slide.
Yes, sir. I'm sharing the screen, sir. Can everybody see?
No,
No,
sir.
we are not.
Can they see, sir? Can you see?
Yes.
So this was a RIRS where some residual stones were left. So I was wondering why the stones are left. So we just started doing the check nephroscopy. So most of the calyces are appearing clean and some mild debris appearing somewhere. But then I realized that these are small stones and there was one small stuck there. So all these we are removed. These were not the major stone load. But in the lower calyx, there was somewhere a stone which we had probably missed. So when I went down there, I realized that okay, let me just check and use the passive deflection. That means you're already deflected and then you deflect. Can you see the stones in the lower calyx? But even these, when I was removing that, I noticed this small opening here, just behind the stone. So I realized that there is a calyceal diverticulum there. Behind this stone, there is a small opening. Did you see that opening?
Yes.
So it was a very, very difficult position to reach there. Now there is that small opening there. So after
Mm-hmm.
removing the stones, we're trying to reach that small opening. Now the very small opening there, through which I have to put the laser fiber here. And it is so delicate that I'm thinking that if I push a little more, this infundibulum is going to tear. Okay, so somehow with a lot of difficulty, I managed to put my laser fiber in that hole. Okay, again it got dislodged. So it was very difficult to focus it in that hole. But somehow I'm trying and trying, and Finally, I managed to reach that and open it up a bit. Okay, can you see? There is a calyx inside with a stone. So I managed to reach inside, but now it started bleeding. Can you see? Now that it started bleeding. So my concern now was not the stone, but this bleeding. And it's like a spurter. Now, with so much difficulty, I reached there with that laser fiber. And now, how delicate it is, if I'm going to break this infundibulum, it is going to bleed more. So I was trying to defocus the laser, and after some time, I could really, with lot of difficulty, reach there. So my laser fiber is a little bit far away. I'm not touching the bleeder. Still, I'm trying to adjust it. This is completely unedited. I'm just showing you what I was trying to do. So now I know my light is there. I'm still not able to see it. But defocusing the laser, I just fired on that little bit. So you saw I'm not touching that area, but the fiber is a little bit far away. And this was in the hemostasis mode. And by God's grace, it stopped. And I came out.
Beautiful video.
Yes.
Very nice.
Yes.
Superb.
A good experience for all those, because nowadays most of the students are also doing RIRS.
But no one will show you something like this.
Yes, very, very good. Thank you, Hiren.
Thank you, sir. I found it. I said it's better to show it today only.
Yeah. So, friends, we are now completing our symptomatology, and from next time we will be Harshiv and Rahul. They will share all the cases, the date wise, and then we will go ahead with the case presentation.
Okay.
Right? So,
Yes, sir.
Ganesh bhai, we will let you know all your cases, malignancy, and we
No
will need
problem.
your support because there are some cases which we don't have at present, like testicular tumor. So, if you have something, please
Yes, sir.
give
I
us
will have,
so
don't
that.
worry. No, we'll make
Okay,
it. Don't worry.
very good. Okay, then we'll give you the details. Okay, thank you. Thank you, all of you.
Thank you,
Thanks.
Gaurang
Thank you,
sir,
sir.
Ganesh bhai,
Bye.
Vilas sir, Gite sir,
Sable sir, Sable
students,
ji, thank you
Thank you,
very
sir.
much.
and Harshiv and Rahul bhai. Thank you, everybody. Good night.
Bye. Good night, everybody.
Thank you,
Thank you.
Good
sir.
night.
Thank you.
Good night. Yeah.
Good night. राहू दे. नाही ती नाही घेऊन जात. मी काही प्रेझेंट नाही करत आहे, वही मी शिकायला जातो. चलो, गाडी चावी.
I have to end the meeting now.
मी सुसू करून घेतो.